Hello, I'm Kristen Barona, and this lecture will cover ultrasound-guided arthrocentesis of the hip, ankle, and wrist. So let's start with a case. A 52-year-old female with a history of diabetes presents with right ankle pain for 5 days. She had twisted it 4 weeks ago, but was able to walk on it and had had no issues until 5 days prior when she presented to an urgent care for swelling and pain. An ankle x-ray showed no fracture, so the patient was told it was a sprain and to continue rest, ice, and NSAIDs. She now presents with worsening pain. Vitals are as shown. On exam, you note a swollen right ankle without significant erythema that is tender diffusely. Pain is elicited with both active and passive range of motion. So you perform an ultrasound of the ankle, which shows a large effusion at the tibio-talar joint, as indicated by the arrow. You then perform an ultrasound-guided arthrocentesis of the ankle. The cell count returns with 108,000 WBCs, 96% neutrophils, and no crystals. Orthopedics is consulted and admits the patient for a washout. There are several reasons for why you may want to use ultrasound to guide your arthrocentesis. Arthrocentesis of the hip, ankle, and wrist joints can be challenging to the provider, as these joints can be difficult to examine due to their anatomy. Visualization of joint effusion on ultrasound can lead to improved time to diagnosis. Ultrasound-guided arthrocentesis can be safely done by the emergency physician without the need for fluoroscopy or orthopedic consultation. Ultrasound can help avoid injury to the surrounding neurovascular structures, decrease pain and discomfort associated with the procedure, and lead to improved patient satisfaction. After this lecture, learners should be able to identify effusions in the hip, ankle, and wrist with ultrasound, and understand proper probe placement and technique for ultrasound-guided arthrocentesis of the hip, ankle, and wrist. We will also review some pearls and pitfalls of ultrasound-guided arthrocentesis and some of the evidence behind it. In order to perform an ultrasound-guided arthrocentesis, the provider should be familiar with the appearance of different musculoskeletal tissue on ultrasound. We will go through classic ultrasound appearance of bone, tendons, nerves, muscle, cartilage, and fluid. Bone appears bright and hyperechoic with a uniform posterior shadowing. Here we see a patella and femur. Tendons are regular fibular structures with an echogenic appearance. This example is the quadriceps tendon. Nerves also appear echogenic on ultrasound and generally accompany the vascular structures. This is the distal sciatic nerve in the popliteal fossa. Muscles demonstrate a distinct echogenic appearance with internal striations. This is a short axis view of muscle. Cartilaginous articular surfaces appear as a thin anechoic or black rim at the joint site. The thickness of cartilage should be less than 0.5 millimeters. This is the talotibial joint. Fluid appears anechoic or black on ultrasound. A fluid-filled area in communication with the articular surface is suggestive of a joint effusion. Here are two examples. Now, let us talk about ultrasound-guided hip arthrocentesis. The hip joint is the articulation of the pelvic acetabulum with the femoral head as shown here. The hip joint is located inferior to the inguinal ligament. Psoas major and iliacus muscles cover the anterior surface of the hip joint, and femoral artery, veins, and nerve course anterior to the hip joint. In order to identify the hip joint using ultrasound, use the curvilinear probe for most adults and the linear probe for most children. The patient should be supine, with slight external rotation of the hip if tolerated, to better visualize the structures. Place the probe in the sagittal oblique plane parallel to the femoral neck, with the probe marker towards the umbilicus, as indicated by the arrow in the photo. The probe should be lateral to the femoral neurovascular structures. This slide shows what the hip joint would look like under ultrasound. To the left of the screen, you can see the acetabulum articulating with the femoral head. The iliopsoas fibers are seen superior to the hip joint, and deep to that you can see the femoral neck and the anterior synovial recess. The anterior synovial recess is the most sensitive location to identify a hip effusion. Here you can see a side-by-side comparison of what a hip joint looks like with and without effusion. The effusion is the anechoic or black fluid collection just anterior to the femoral neck, as seen on the right side of the screen. A pathologic hip effusion will be greater than 5 millimeters from the joint capsule to the femoral neck, or greater than 2 millimeters larger compared to the contralateral side. An effusion can have a convex appearance and would obliterate the stripe sign, which is the stripe-like appearance formed at the anterior femoral neck between the fascial layers of the iliopsoas muscle, which you can see here identified by the blue circle. Now let's discuss performing the ultrasound-guided hip arthrocentesis. The equipment needed are as follows: sterile gloves, gown, and mask, sterile drape or towels in order to create your sterile field, sterile ultrasound probe cover and gel, 1% lidocaine and a 25 gauge needle for local injection, chloroprep or providone iodine as an antiseptic solution, a 10 to 20 cc syringe, and an 18 to 20 gauge spinal needle for aspiration of synovial fluid. You can use a linear high-frequency probe in thin patients or a curvilinear probe for larger patients. First, identify femoral vessels and nerve. Your entry location should be lateral to these structures. Then, identify the hip joint and ensure a hip effusion is present. Keep the probe in plane with the femoral neck, which is an oblique sagittal orientation, with the probe marker towards the patient's umbilicus. You may need to slightly externally rotate the hip in order to visualize the effusion better. Place the ultrasound machine on the opposite side of the patient's gurney. That way, you have the screen directly in front of you and would not need to turn your head frequently in order to see the screen in your field. Your probe marker should be directed superiorly and towards the acetabulum, and your probe should be positioned in a sagittal oblique plane parallel to the femoral neck. You should perform this procedure using an in-plane technique where your needle is parallel to the ultrasound beam. Anesthetize the skin with local anesthetic at the point of entry, then switch to the 18 or 20 gauge spinal needle. Make sure to enter the skin in the midline of the probe and visualize your needle the entire time in order to see the full length of the needle as it is advancing into the joint capsule. Aspirate as you advance the needle. This example is being performed on a cadaver, but remember you should always perform this procedure with full sterile technique. In obese patients, the panish should be pushed superiorly and maintained in this position by an assistant or taped securely. Let's review some ultrasound-guided hip arthrocentesis pearls. Remember that an effusion should be greater than 5 millimeters in width or at least 2 millimeters larger compared to the opposite side. Comparing with the opposite hip can often aid with the diagnosis of a hip effusion. You can externally rotate the hip to increase your target size. Make sure that you identify the neurovascular structures and avoid injuring them with the needle. Also, remember not to go through infected skin and always perform this procedure in a sterile fashion. Next, let's discuss the ultrasound-guided approach to ankle arthrocentesis. The ankle joint is the articulation between tibia, fibula, and talus. When examining the ankle joint using ultrasound, place the high-frequency linear probe in a sagittal plane with the probe marker facing the patient's head. You may start by placing the probe anteriorly over the tibia, then sliding down to visualize the ankle joint. You can identify the tibia as the bony structure closest to the probe marker on the left side of the screen. The talus bone is seen here as the other bony structure farther away from the probe marker. The ankle joint appears as the valley-shaped space between the tibia and the talus. Note the absence of free fluid in this space. Remember, the thin anechoic rim just over the cortex is cartilage. Also note the tendon overlying the ankle joint in this image. Here are two images of the ankle joint on ultrasound. Note the presence of a joint effusion on the image on the right, as the anechoic or black area between the tibia and the talus. Here you see an ankle joint with a moderate effusion, and you can see the pulsating dorsalis pedis artery coursing over the fusion pocket. It's important to identify the course of the artery in order to make sure that you do not inadvertently puncture it while performing arthrocentesis. Sliding the probe medially will likely provide safer access. The equipment needed for ultrasound-guided ankle arthrocentesis include sterile prep solution, lidocaine for local anesthesia, sterile gown and gloves, sterile ultrasound cover and gel, and sterile 20 to 22 gauge needle and syringe. The ideal ultrasound probe for ankle arthrocentesis is the high-frequency linear probe. This image shows the medial approach of ultrasound-guided ankle arthrocentesis. The patient should be positioned with the knees bent and the ankle plantar flexed. The probe should be just medial or over the tibialis anterior tendon, and the needle insertion would be medial to the ultrasound probe, with care not to go through the tibialis anterior tendon. The anterior medial approach is shown here. The provider should stand on the contralateral or medial side, and the ultrasound should be positioned directly across from the provider. Care should be taken not to go through the anterior tibialis tendon or the dorsalis pedis artery. Note that given the anatomy of the area, the preferred technique is an out-of-plane approach, where the needle is inserted next to the ultrasound to access the joint space. In this technique, only a needle cross-section and not the entire length of the needle will be visible. Center the joint space in your screen so that your needle will enter at the center of the probe. Anesthetize the skin with local anesthetic at the point of entry, then switch to a 20 to 21 gauge needle. You will need to insert the needle at a steep angle, about 80 degrees, to ensure direct insertion into the joint of fusion. Once you feel bone, withdraw 1 to 2 millimeters and aspirate the effusion. As you watch this video, note that the ultrasound screen in the corner shows only the needle in cross-section. The lateral approach is shown on the image here. Again, the preferred technique is an out-of-plane approach where the needle is inserted next to the ultrasound to access the joint space, this time lateral to the probe. The probe should be just lateral to the extensor digitorum longus tendon, and remember to use full sterile technique. So let's review some pearls. Remember, a thin rim of cartilage can be normal, so compare to the opposite ankle. Position the ultrasound across from you for ease of visualization and have the patient with knee flexed and ankle plantar flexed. Identify and avoid the dorsalis pedis artery and tibialis anterior tendon. Your needle entry will be a steep out-of-plane approach, so you will not see your needle until it enters the effusion. Remember, don't go through infected skin and maintain sterile precautions. Lastly, let us discuss how wrist arthrocentesis can be done with ultrasound guidance. The wrist joint is comprised of the radiocarpal space and the intercarpal spaces, which communicate with each other and the radiocarpal space. The important landmarks for choosing the needle entry site are Lister's tubercle and extensor pollicus longus. Lister's tubercle can be palpated as the bony prominence on the dorsal surface of the distal radius. The extensor pollicus longus tendon comprises the ulnar border of the anatomic snuff box, and you can identify it by asking the patient to extend the thumb. In order to evaluate the joint for effusion, first place the linear probe in a sagittal plane on the dorsal wrist with the probe marker facing proximally. Keep the wrist slightly flexed and as ulnarly deviated as is tolerated by the patient. Avoid applying too much pressure with the probe, as this may compress small joint effusions and make them difficult to detect. Identify the radius bone proximally and the carpal bone located distally. The joint effusion appears as an anechoic fluid collection in between these two structures. The equipment needed for ultrasound-guided wrist arthrocentesis include sterile prep solution, lidocaine for local anesthesia, sterile gloves, sterile ultrasound cover and gel, and sterile needle and syringe. The ideal ultrasound probe for wrist arthrocentesis is the high-frequency linear probe. Similar to the procedure with the ankle joint, we recommend an out-of-plane approach to ultrasound-guided wrist arthrocentesis, as is shown here. Note the steep angle of needle entry in this image. To perform ultrasound-guided wrist arthrocentesis, first, sterilely prepare and drape the wrist. Center the radiocarpal effusion in the middle of the ultrasound screen. Numb the skin with local anesthetic at the site of needle entry, just radial to the ultrasound probe. Then, switch to a 21 gauge needle and insert at a steep angle at the center of the probe in an out-of-plane fashion. Note that the wrist is kept slightly flexed and ulnarly deviated. On the ultrasound screen, the needle is seen only just as it enters the wrist effusion. Once the wrist joint is penetrated, fluid is aspirated into the syringe. Let's review some pearls. Having an assistant place the wrist in flexion and ulnar deviation with mild axial traction will really help open up the radiocarpal space. Remember to compare to the opposite wrist and center the effusion on the ultrasound screen. Your needle entry will be a steep, out-of-plane approach, so you will not see your needle until it enters the effusion. Remember, don't go through infected skin and maintain sterile precautions. So how good are emergency physicians at diagnosing effusions? There's limited evidence. However, Vieira et al. Investigated the diagnostic accuracy of pediatric emergency medicine physicians performing bedside hip ultrasound for effusions with radiology ultrasound as the gold standard. In all 55 hips studied, the sensitivity of bedside ultrasound was 80%, with a specificity of 98%. However, in the 28 symptomatic hips, sensitivity increased to 85% and specificity was 93%. When provider confidence was high, sensitivity increased up to 90%. Adhikari et al. Looked at a convenient sample of 54 patients presenting with joint pain and/or erythema who had a point-of-care ultrasound performed. Treating providers were asked if joint arthrocentesis was planned, and then study investigators performed an ultrasound. After the results of the ultrasound, the plan changed in 35 of 54 patients, with 27 planned aspirations not being performed and 8 unplanned joint aspirations being performed. Only one prospective randomized control trial of ultrasound-guided versus landmark-based joint arthrocentesis has been performed in the emergency department population. Weiler et al. Investigated the utility of ultrasound guidance for knee arthrocentesis and found no difference between the success of ultrasound-guided arthrocentesis, which was 95%, and landmark-based arthrocentesis, which was 93%. Given the very high success rate in traditional knee arthrocentesis, it is not surprising that ultrasound did not have much added benefit. However, Balint et al. Investigated ultrasound-guided arthrocentesis in the rheumatology setting and found a huge difference in success rates of arthrocentesis in a sample of 64 arthrocenteses of multiple joints, with 32 ultrasound-guided and 32 landmark-based. They noted a 97% success rate with ultrasound and only a 32% success rate with traditional techniques. Though prospective randomized trials on more difficult joints are lacking in the emergency literature, there are numerous case reports of ultrasound-guided arthrocentesis of the hip and ankle. So here are some tips that can help with ultrasound-guided arthrocentesis. Remember to familiarize yourself with the anatomy and the landmarks for performing the procedure. Always compare to the opposite side to aid with diagnosis of effusion. Make sure that you identify the neurovascular structures and avoid injuring them with a needle. Also, remember not to go through infected skin and perform this procedure in sterile fashion. Pitfalls include not getting the best view possible with ultrasound prior to attempting the procedure, not anchoring your ultrasound hand prior to performing the procedure, not positioning the ultrasound in an ergonomic fashion, and not using sterile ultrasound gel. Remember, for hip arthrocentesis, you will use an in-plane technique advancing towards the femoral neck, and for ankle and wrist arthrocenteses, you will be using an out-of-plane technique. So getting back to our patient, blood culture ×2 and synovial culture grew out MSSA. The patient had an OR washout ×3 with posterior tibial bone windows, given concern for osteomyelitis. She was ultimately discharged home on 6 weeks of IV oxacillin and was doing well at her 2-month follow-up. Thank you for watching this tutorial, and hopefully you found it educational. Here are the reference materials for further review. A big thank you to Dr. Dina Saif and Dr. Amin Abdi for their images and help in preparing this lecture.